दिसतंय ना त्याच्यावर 3 डॉट्स दिसतंय.
माझ्या नाव हो दिसतंय.
Click that.
हो.
You will see the background. You will see virtual background असं एक तुला दिसेल.
Oh, choose virtual background.
So click it and make it none.
Okay. Okay.
Yeah, now it is better. See?
Yeah.
Thank you. You landed back to Nagpur.
Yeah, I'm glad to be back. Thank you.
कसं झालंय हे so many times we are on virtual platforms, so this has really become easy to communicate.
Yeah.
Because sir.
Yes, sir.
Tomorrow I am speaking the same topic, same title for the National Board of Education webinar.
अच्छा sir.
Same title.
मुझे link भेज देना sir. I will try to learn some more things.
I don't know. You may have to. I don't know. You may have to just discuss and correct a lot of things for me.
नहीं sir.
I'll be back in 2 minutes, sir. I'll be back in 2 minutes.
Yeah, even I. I'm putting off my video.
Good evening, Anita madam.
Good evening.
Hello,
Shubada.
आज आमचे सेक्रेटरी नाही
Hi.
आहेत, डॉक्टर अविनाश भोसले.
Hello.
श्रीनगरच्या वाटेवर आहेत म्हणाले. मेसेज पाठवला होता. He had sent a message posted a message on the group.
Yes. गेडू सर नमस्कार.
सर अनम्यूट करा. अनम्यूट
केलं मी अनम्यूट केलं. नमस्कार मॅडम. How are you, Anita?
I am good, sir. How are you, sir?
I'm always fine.
वर्षा मॅडम मॅडम.
Yes, ma'am. Yes.
मीटिंग सुरू होईस तर अजिबात रेकॉर्डिंग ऑन करू नका.
नाही मॅम, स्टॉप आहे रेकॉर्डिंग.
आय जस्ट वॉन्टेड टू इन्फॉर्म यू, कारण मग मागच्या आयुष्यात आपल्याला जरा तुमचा तो एडिट करून व्हिडिओ अजून येतोय माझ्याकडे म्हणून.
ओके.
I think you will be perfect in putting up the PPTs of CV this time. Harsha madam?
Yes, ma'am.
Yeah.
वर्षा मॅडम आपला क्रम आहे ना त्याच्यानुसार CV PPTs डिस्प्ले करा.
येस मॅम.
हा तुम्हाला माहिती आहे ना क्रम, आहात ना तुम्ही त्या ग्रुपमध्ये?
हो हो.
हा.
It's practically 7 now. I think we can start.
Yeah, we can start. Sir, we'll wait for another two minutes, and then it is 6:58. Because usually the platform gets full by 7:05, 7:10. So I think Sare sir has yet to join.
साड्या पहिल्यापासून असंच आहे. नाही मी बोलतोय कारण माझा क्लासमेट येतो.
I know that, sir.
म्हणून म्हणलं.
Yeah. टाटा आपलं सोलापूर ना सर?
सोलापूर माझा क्लासमेट थ्रूआउट MBBS.
Yeah.
साड्या येणार का? जॉईन करतोय.
He's joining, sir. Anita, will you please call him so that we will start once he joins?
Yes, I'll call him.
Samir sir, good evening. So before the lecture only we have started getting the queries.
Yeah, I can see that. I'm just reading.
Sare sir is joining.
Okay.
2 minutes he is joining.
Okay, so should we start, Anita ma'am?
Yes, we can start actually. Good evening, Kundra sir.
Good evening, ma'am. Good evening.
चलो कुंद्रा सर चालू करो.
सर आपको चालू करना है, मैं तो
सर चालू करते हैं एक सेकंड से.
नहीं चालू तो शुभदा मैडम करवा रहे हैं.
We'll start, sir. Respected Dr. Kundra sir, faculty for today's webinar. Respected Dr. Gedu sir, dear Dr. Shubada Deshmukh madam, and all the members who have joined for this webinar. I'm really happy to have expert chairpersons and expert faculty for the today's webinar. And the feedback I got when I circulated the message today that it is a very practical and important topic you are discussing. So I'm sure that we will be having a lot of discussions at the end of sir's lecture, and we'll have 3 expert people to answer all the queries.
I agree with you, because the thing is, if you see, the Difficult Airway Society has started the what you call guidelines for the difficult ventilation, difficult intubation, but they never, I mean, even they have said cannot intubate, cannot ventilate, but they never put that I can intubate, but I cannot ventilate. That is not there in the guidelines.
Yes, sir. So let's start with today's webinar. I request Dr. Anita madam for further proceedings.
Yes, thank you, Manisha madam. And Varsha madam, please display Dr. Gedu sir's yes. So I welcome Dr. Gedu for this today's session of master class, and actually Dr. Gedu is like a Bhishma Pitamaha of ISSP
ये
and
मेरी ऐसा मत बोलो यार.
does not really need any introduction. Sir has done his DA and MD from Solapur Medical College, and he has worked in Tata Memorial Hospital for many years, and he has many students around Maharashtra. At present, he is working at D.Y. Patil Medical College, Navi Mumbai. He is a recognized PG teacher for MD, DA, and he has been examiner and paper setter for various examinations. He has huge number of presentations, more than 400 presentations, and he has participated in many live demonstration of nerve block workshops. He is a very avid teacher. He really loves to teach, and we are very happy today to have Dr. Gedu as an expert chairperson for this important session. So with this very short introduction, I request Dr. Who is going to introduce? Dr.
Dr.
Sade?
Samir. Dr. Samir, sir. Dr. Samir.
Yes, sir.
Thank you. Varsha madam, kindly display the introduction slide of Dr. Shubada Deshmukh. Thank you. It's my pleasure to introduce our second expert for this today's master class, Dr. Shubada Deshmukh from Nagpur. She is professor in the Department of Anesthesiology at NKP Salve Institute of Medical Sciences and Research Center and Lata Mangeshkar Hospital from Nagpur. Nearly 30 years of experience in UG and PG teaching, also a recognized guide and examiner for MD and DA. She has been working as there as a faculty in the various national and state conferences. Besides anesthesia, her special interest is in intensive care. She has got many publications in national and international journals, and recently she has been awarded the Savior by the Association of Medical Women for services rendered during COVID-19 pandemic. Thank you. Welcome, madam.
Samir, sir, there is lot of disturbance from your side, most probably, because yes. Once you start the mic, there is disturbance. Let's check later on also.
I think you can keep it muted during the proceedings, and
Yeah.
meanwhile we'll see what is the problem.
अरे साडे आले त्याला पण बोला.
Yeah.
तो चिडेल नाही.
Sai sir, will you introduce our faculty today, Dr. Kundra sir?
साडे अनम्यूट कर.
Sai sir, unmute kara please.
Oh, yeah. Good evening to all. It is my pleasure to introduce stalwart in anesthesia in India, Dr. Pankaj Kundra. Since so many years, I have never ever missed his lecture in the national our conferences. So, to introduce in short, most of the Indian anesthetists, they know him very well as a teacher, but still I need to introduce him. He is currently holding the position as a professor and dean for the Department of Anesthesia and Critical Care Medicine in JIPMER, which is one of the premier institute in India. In short, few achievements sir has given to us. Otherwise, I know he has got many more. He's been awarded as an ISA Life Member Achievement Award in 2015. He has given so far 9 oration lectures. To his credit, there are 136 publications which are peer-reviewed journals, and he is a president of AIDAA National. He's adjunct professor in KMC Manipal also. His special area of interest is airway, critical care, and anesthesia. So, welcome, sir, and we'll proceed with the lecture from Dr. Pankaj Kundra. Thank you so much.
Thank you very much, sir. With your permission, the chairpersons, may I proceed with the lecture, sir and madam?
Yes.
please.
So at the very outset, I'm extremely humbled and grateful to all of you who have given me this opportunity to share my views on difficult ventilation after intubation. The chairpersons, the respected chairpersons, Dr. Gedu, Dr. Shubda, Dr. Manisha, and others who have helped me to come to this platform and given me this topic. Well, difficult ventilation after intubation is one of the issues which we face many times during our regular practice. What can be the problems? So for convenience of understanding, I have just divided into two sections. One can be equipment related, the other can be patient related. So how do we deal with the equipment related issues? You may not be able to ventilate a patient if there are major leaks or if there is an obstruction. Both these two criteria can exist. So if there is a major leak in a breathing circuit, either the patient can be on a ventilator or is being manually ventilated. What you will find is that there will be signs of hypoventilation. The end tidal will slowly rise, the heart rate will rise, and the SpO2 is likely to fall, but it may lag behind the rise in EtCO2. If you're manually ventilating, you'll find that there is inadequate ventilation, delay in refilling of the reservoir bag. And if the patient is on a ventilator, a low pressure alarm and a low volume alarm would be triggered, and there also would be a circuit leak alarm. How do we troubleshoot? Immediately take the patient on manual ventilation with 100% oxygen. Try to increase the fresh gas flow to match the leak which is happening. At times, you'll have to use the oxygen flush. Close the APL valve and make sure we maintain somehow the anesthetic depth. Now, after doing these, again, we have to reassess whether we are able to ventilate or no.
Sir, please unmute yourself.
Sir, please unmute.
Audio early. Don.
Varsha madam, sir is not able to unmute.
Am
Yes,
I
sir.
audible now?
Yes, sir. Yes, sir. You can go from the second slide.
Fine. Was I unmuted in between or did I not?
Just now, when we told you just 1 minute before that.
Okay, so from where shall I start from here? Is it all right?
Yeah, yes, sir. Yes, sir.
So the causes of not being able to ventilate can be because of a major leak in the breathing system. But the criteria for hypoventilation would be visible to all of us. There'll be a rise in the end tidal carbon dioxide. The heart rate is likely to rise and the SpO2 may fall. If the patient is on manual ventilation, you'll find that there is a delay in refilling of the reservoir bag and the ventilation is inadequate. If the patient is on ventilator, there will be a low pressure alarm and low volume alarm which would be triggered, and there can also be the circuit leak alarm which can be triggered. The immediate rescue should be that you switch on 100% oxygen, increase the fresh gas flow to match the major leak which is happening. Sometimes you may have to use the oxygen flush. Close the APL valve completely and make sure we maintain the anesthetic depth. Again, reassess whether we are able to ventilate or not. If it is still difficult to ventilate, then you will have to check the endotracheal tube, come to the connectors, see the circuit, the HME filters, the unidirectional valves, the soda lime canister, maybe there is a major leak there, the vaporizers if they're not seated well, and of course the ventilator. If you're still not able to ventilate at all, then switch over to Bain circuit where you can give 100% oxygen, but at the same time make sure you maintain the depth of anesthesia using IV agents. If you're not able to ventilate still, switch over to a rebreathing bag like an ambu bag. And still, if you're not able to ventilate, then it is a problem with the endotracheal tube or the tube size. You may have to extubate and do bag mask ventilation. So this is in short how we can proceed if there is a major leak in the system and you're not able to diagnose. This is a stepwise algorithm which I have written down for us to follow in case of major leaks. Now the second aspect of equipment can be airway obstruction. Airway obstruction can occur after intubation, and the indicators of airway obstructions are that there will be a high airway pressure alarm which will be activated. It will be difficult to ventilate the patient, and there is going to be a rapid decrease in the end-tidal CO2 because hardly anything is going in and coming out. And you may find that there is a steep upsloping of the capnographic trace if you're able to have one. The next test which we need to do is, if there is a kinking of the tube or an obstruction, we try to pass a catheter to the tube to see if it can go down through the endotracheal tube to check the patency. And if it is not going down, then you will have to check how to make sure that the tube is replaced, or wherever the kinking is happening, we need to look at it. Remember, oxygen desaturation may have a lag behind the decrease in EtCO2. So the first indicator would be a fall in EtCO2, and decrease in oxygen saturation will occur later. This is one of the case reports we have published. I'm sure it's not an intubation, but just to tell you that a lot of us do face difficulty in ventilation after insertion of supraglottic airway. And this patient had regurgitated an ascaris during anesthesia and was creating signs of airway obstruction and wheeze. And this is what we found when we removed the LMA to replace it with another one. But make sure that whenever you have supraglottic airway devices, check for malposition or an obstruction, but most commonest is the malposition. And you may have to replace or reposition it to get proper ventilation through a supraglottic airway device. I know it's not part of intubation, but I thought it worthy to be mentioned here. Now, the other commonest problems which are likely to happen is with the tracheal tube cuff. This tracheal tube cuff can be overinflated. It can cause intraluminal obstruction, which actually you can see at this particular point that the lumen of the endotracheal tube is compromised. It can also cause herniation of the cuff so that the cuff comes and obstructs the distal lumen of the endotracheal tube. So both phenomena are likely to occur, especially when you overinflate the endotracheal cuff tube. And these are the CT images which you see. This is a full diameter of the endotracheal tube which you can see. This is the inflation line. And when you overinflate, you will find that the tube is completely compressed. Look at the diameter where here, how it has expanded. It has actually expanded to dilate the trachea and therefore compress the tube. So these phenomena or these problems can occur if you are not able to, if you inflate the cuff not with an appropriate volume. So a desktop experiment which was conducted to find out what are the reasons and how we should troubleshoot them. This is generally seen when the tubes are pre-warmed to a temperature of 37 degrees centigrade. The tubes and the cuff get softened, and if the tube gets softened, it can have a tendency to get compressed with the pressure of the air. Partial to complete occlusion of the endotracheal tube can occur if you put in more than 10 ml of air into the pilot balloon. And it is seen that the sizes with which you can have this occlusion is with 3.5 to 6.5 millimeter internal diameter endotracheal tubes. And if the cuff pressure readings are more than 120 centimeters of water. So these are the certain things which we need to look at when we try to see that there is a cuff which can cause intraluminal obstruction or herniation. So the lessons learned from that is that it is good to have a cuff pressure monitor so that you inflate the cuff to an appropriate pressure. We generally clinically try to palpate the leak and then slowly inflate the cuff till the leak just disappears. I think that's a good technique and we all can adopt if we do not have a cuff pressure monitor. But remember, slight overinflation of the cuff can impede tracheal mucosal blood flow and later on cause mucosal ischemia, especially if the tube is going to be in situ for a long surgical procedure. With time, when you keep giving nitrous oxide, the intra-cuff pressure keeps increasing because the nitrous oxide tends to diffuse into the cuff and cause pressures continuously. So either you have a intra-cuff monitor or you keep palpating the tube, making sure that at times you deflate the cuff slowly to see that the pressure is not being generated inside the cuff. But I believe these are cheap options. Cuff pressure monitor, we must keep it besides us to make sure we appropriately inflate the cuff with adequate pressures. The cuff pressure monitor which we use, if you have to prevent aspiration, it requires about 18 millimeters of pressure. This is what has been documented. But if you increase beyond 25 millimeters of mercury, which is the capillary pressures in the tracheal mucosa, you're likely to cause tracheal mucosal ischemia. So just remember that the cuff pressure should always be less than 25 millimeters of mercury, but it all depends upon the size of the tube. If your tube is smaller in size, then your cuff pressures may be high, but the area in contact with the tracheal mucosa may be very less. So you must remember that we need to take or choose appropriate size of endotracheal tubes if these pressures are going to mean something to us. There's another case report which has been recently reported. When there was a complete obstruction because of the inflation line when it was used, when the cuff was inflated. So this inflation line actually blocked the proximal portion of the tube, and when the cuff was deflated, the tube patency was nearly complete. So what does it tell us? It tells us that if you try to pass in a catheter, you may be able to rule out majority of these tubal obstructions which are seen with various manufacturing defects or by us. What are the lessons learned from the last slide which we saw? It's always good to check your equipment and adjuncts, initially perform a visual inspection, inflate and also do a vacuum test. Many a times, people only inflate. Remember, all anesthesia equipment and inflatable cuff devices, you need to do a vacuum test. That is, you aspirate and then see whether the cuff reinflates. If it reinflates, there is a leak. But if you are able to maintain that collapsibility of the cuff, the pilot balloon, the inflation line, and the cuff is surely are good and there is no leaks around. So vacuum test will not only test the cuff, it will test the inflation line as well as the pilot balloon and the valve there. So always perform the vacuum test for LMAs, for endobronchial or endotracheal tubes to make sure that they are working well and there are no leaks. And also do an inspection just by inflating the cuff once, seeing how much pressure is administered, whether there is a herniation of the cuff, whether there is some part of the cuff which is loose, which is not manufactured properly and it is thinned and it tries to balloon out. So just by inflating the cuff of the endotracheal tube and then deflating and creating a vacuum would be good enough to check your air equipment every time you use it. Do not use reuse the single-use devices. this most commonly happens, and when you start using them, the problems are there because the material which is meant is only for a single use and not for repeated use, and the devices can malfunction. Always have a rescue ventilation device, that is a umbu bag, which should be always available, that in case you're not able to, the machine is or the circuit is not working well, you have a doubt, at least start with a umbu bag ventilation and always have an alternate oxygen source. This is another case report which we do see, at least personally I have seen with the tracheostomy tubes as well, that the bevel of the tube is abutting the tracheal wall. So here is the endotracheal, the lumen, and when you do a bronchoscopy, you find that the lumen is totally abutting the tracheal wall. This can happen at times when the tube becomes soft or when the tube is actually not of appropriate size. So this kind of a problem of the lumen abutting to the tracheal wall can be seen predominantly in children, in obese patients who have a BMI of more than 30. In children, it happens because of repeated movements of the head and neck during surgery. There is a disease called Frostier's disease, where there are large osteophytes in the cervical vertebra, which can cause the lumen of the tracheal wall to be nearer to the endotracheal tube lumen and cause obstruction. And the only way you can rule out is either by passing the catheter that it is not going in, or having a real-time view by doing a fiber optic evaluation. I feel this is probably the best way of doing it if we have this instrument with us, the fiber optic. What else would we see? You will find that there is insufficiently delivered tidal volume. So it's always good to monitor the inspired and the expired tidal volume. The Murphy's eyes, which is supposed to be taking care of this problem, may not provide sufficient volume to be delivered to the patient. And you may have high pressure alarms still being triggered. And if you look at the airway pressures, it will be persistently high. I've just given a rough range around about 30 to 35, and it is not coming down. At times it's good to rotate the tube, and you may find that the ventilation has become all right. So these are the maneuvers which you will have to do, and these are the susceptible cases where such problems can occur. Now let's come to the patient factors. I have divided them into three broad patient factors which we can normally see. One is an esophageal intubation. If you have a tube in esophagus, you will definitely not be able to ventilate. You may be thinking you are in trachea, but it's always good to do the check for an esophageal intubation. Always a wise thought that have someone check the tube, auscultate the epigastrium, look at the excursions, whether you're finding any excursions of the chest, look at the capnograph, do all these tests to make sure that the tube is not in the esophagus. The other two common problems are pneumothorax and bronchospasm. So let's deal with the upper two. I'm sure all of us know how to rule out esophageal intubation. I'm not going to go in details about that. So this is a image or a video of pneumothorax. If you look at this, the sliding is not happening here. It's only happening to this part of the lung. So if this happens, that the sliding sign is visible in this part and this part is stationary, this is where we call it as a lung point, where we have partial pneumothorax which has been created. So the sliding sign would be absent in that area, the B lines would be absent, the A lines may be present, and that's where the lung point is. And this is generally used with a 2 to 10 megahertz probe, or even a linear probe is good enough to find out this. So partial pneumothorax can lead to such problems. You may have high pressures, you may be able to ventilate, but you may find that the airway pressures are high and you're not able to achieve adequate ventilation. It is probably some amount of difficult ventilation which you may encounter. If you go to the M mode, you will find a seashore sign if the lung is normal, and if it on the part where the pneumothorax has occurred, you will find a stratosphere sign. This is a patient who was admitted in our ICU. You can see the ventilator circuit here with a tracheostomy tube. This is the X-ray chest which we took earlier, but we found that the patient had difficulty in ventilation. The saturations were not satisfactory and the EDCO2 was going up. And if you find in the X-ray chest, not very discrete, but there was some sign of a partial pneumothorax. But as soon as we did an ultrasound, you could see that there's a barcode sign where the pneumothorax was not there, and the seashore sign just on top of that bleb of pneumothorax which was created. Now let's come to the intraoperative bronchospasm, which is a very common entity and which need to really look into how to treat this factor. The differential diagnosis would be endobronchial intubation, pneumothorax, pulmonary edema, or kinked or obstructed endotracheal tube. So I just want all of us to focus your attention to the next 3 slides, which probably would be very important for us. If there is an endobronchial intubation, there will be decreased breath sounds on one side, not on both sides, and generally we see it's on the left. If there is a pneumothorax which has been created, there will be decreased breath sounds on one side. Most often than not, it is an asymmetric chest rise and it will be a unilateral pneumothorax. Pulmonary edema, you will find frothy secretions in the endotracheal tube. You will find crackles on auscultation. And if it is a kinked or an obstructed endotracheal tube, it will be difficult to pass the suction catheter, and you will not be able to remove the secretions. But if the suction catheter goes in, the tube may still be in the esophagus. So please rule out esophageal intubation as well during this particular time. The most commonest effect of intraoperative bronchospasm can be because of anaphylaxis. So if there is bronchospasm which is accompanied by hypotension, tachycardia and rash, we should rule out anaphylaxis. So look at the skin if there are rashes which are appearing. If there is hypotension, if there is tachycardia, try to treat first thing first, that is anaphylaxis. If you look at the intraoperative bronchospasm, if you have an ultrasound with you, you'll find that there are signs of hyperinflated chest where the A lines are more prominent. But if you look at this part of the pleura, it is more reflective. It is highly shining and it is more reflective, and that is one of the signs which you can look at. The other sign is called as a lung pulse, where there is markedly reduced expansion of the chest because it is already hyperexpanded. The air is not coming out of the chest, and the lung pulse confirms it because there is no movement of the chest or the lungs. You'll find that the heart sounds are coinciding with these pulses which you are seeing onto on this particular ultrasound. So this is what you can do to immediately find out if there is an acute bronchospasm where even the wheeze is not possible. It may be a stone chest. I already told you that pneumothorax, you will find that the lung sliding sign is absent. A lung point may be present and you will have to look at the M mode. The sensitivity is about 81% and specificity is about 100%. With endobronchial intubation, on the non-ventilated side, the lung pulse may be present. On the ventilated side, you may have diaphragmatic movements and lung sliding will still be present. If there's pulmonary edema, you will find diffuse B lines. And of course, if there's a kinked or an obstructed endotracheal tube, there will be bilateral diaphragmatic movements which are markedly reduced or absent. Now, how do you go ahead and treat this? How do you manage? The first thing is take the patient on hand ventilation. Start on 100% oxygen. The second thing is try to increase the depth of anesthesia. If it is a mild bronchospasm, you will be able to hear the wheeze. You can give drugs like ketamine and propofol and an IV bolus. Both are very good bronchodilators, as well as they will try to increase the depth of anesthesia. In case you want to use the volatile and the bronchospasm is mild, increase the fresh gas flow and increase the inspired concentrations so that you can increase the depth of anesthesia. Ketofol in the dose of 1:4 is good and 0.1 ml per kg bolus will do. The other part is you can use short-acting beta-2 agonists. Normally, the most rapidly acting one is albuterol, which we do not have in India. I do not have an excess. If you have, you can use this. Or you can use nebulized salbutamol and terbutaline. The other option is anticholinergics like ipratropium. You have to take 500 micrograms a glycopyrrolate of 0.2 milligrams. Remember that the anticholinergics. So these are the maneuvers which you will have to do. And I think there's the noise. Someone can mute it. Now let's come to the patient. Is my video being? I have divided them into three broad patient factors which we can normally see. One is an esophageal. Can you please mute the mic because esophagus, you will definitely not be able to ventilate. You may be thinking you are in trachea.
Varsha madam, please mute everybody else except Dr. Pankaj Kundra.
Wise thought that have someone
Varsha.
Auscultate the epigastrium.
Okay, Varsha madam, are you there?
Somewhere some presentation is.
Yes, ma'am.
Shubda ma'am, please mute everybody.
Shubda ma'am. Shubda
Please
ma'am.
mute Shubda madam.
The other two common problems are pneumothorax and bronchospasm. So let's deal with the upper two. I'm
Yes,
sure
ma'am.
all of us know how to put out this vision.
I think Shubda madam has logged in from two either.
This is an image or a video of pneumothorax.
Varsha madam, please mute Shubda madam.
Yeah, it is actually the sir's presentation that we can hear. I don't know how.
If it's going on the YouTube, maybe you'll have to mute her. That's
Yeah.
Yes, ma'am. Done. Done, ma'am. Done, ma'am. Done.
Still the voice is there. Okay.
Still we can hear some voice.
Right. It's okay now. It's okay. I'm extremely sorry, sir, for the technical glitch. You can please continue, sir.
No, that's perfectly fine. Okay. So I'll just start with the intraoperative bronchospasm management again. Make sure you take the patient on hand ventilation, start 100% oxygen, and try to increase the depth of anesthesia. Ketofol is a good choice because both ketamine and propofol are good bronchodilators, and they would also help to increase the depth of anesthesia if it is inadequate. But if you're using volatile, you can still increase the fresh gas flow and increase the inspired concentration. Short-acting beta-2 agonists like albuterol can be used. If it is available, it's rapidly acting. But if you do not have, you may have to use salbutamol and terbutaline. Anticholinergics, you can nebulize ipratropium about 500 micrograms or use glycopyrrolate 0.2 milligrams IV. But remember, the onset of action is about 20 to 30 minutes. You may not get an immediate relief. To me, the best way to deal with this situation is using epinephrine. An epinephrine IV bolus of 10 to 50 micrograms or given IV or subcutaneously will immediately circumvent the problem. You can even nebulize epinephrine in a dose of 500 micrograms. Believe me, this works wonders. So even if you have anaphylaxis or spasm due to any factor, this is one drug which can be a lifesaver for you. Hydrocortisone, a lot of us give, but the onset of action is only going to occur after 4 to 6 hours. So maybe later on it may be helpful, but it will not be helpful when you are giving it to manage the crisis situation. Magnesium sulfate can be given over 20 minutes, but remember, you will have to give it in a central line. Otherwise, you will not be able to use that IV line after you give this magnesium sulfate in a peripheral line. Now, the time is to focus on the short-acting beta-2 agonists. How do you nebulize in a paralyzed, non-breathing patient through an endotracheal tube? When I ask this question, majority of the people tell me that they will disconnect the tube and take a meter dose inhaler and put it into the tube. All the particles would only be deposited on the tube and nothing is going to go into the chest. So that's not the way of nebulizing it or putting a bronchodilator for a patient with an endotracheal tube who is paralyzed. You will require an inline nebulization. You need an auxiliary oxygen source, and there has to be a T-piece connector between the tube and the HME or your closed circuit, where you can have the beta 2 agonists deposited, and continuously you have to put in oxygen here through an auxiliary source while you are ventilating the patient to get the beta 2 agonist into the patient. Otherwise, it doesn't work. You will not be able to deliver any sort of beta 2 agonists if you don't have this system. So this is how it will be. Make sure this is absolutely upright. If it is tilted, it will also not help in nebulization, because the oxygen, if the Hudson nebulizer is tilted, it doesn't help in nebulization. The capillary action is lost. So this is the arrangement you will require if you want to nebulize beta 2 agonists to the patient, not by giving beta 2 agonists by a meter dose inhaler. It doesn't work at all. Thank you very much. These were some of my views which I wanted to share, the commonest things which are likely to occur because of equipment problems or because of patient problems. And I specifically kept the intraoperative bronchospasm in the last because I thought that is what we normally do, and that is where we need to know what should be the line of management. Thank you very much. It was a pleasure giving this talk to the audience.
Thank you so much, sir. It was really an excellent presentation, and so many things we were recalling, or so many things were like common problems which I thought are getting discussed by you, and it was really fantastic. I would like to have expert opinions of Dr. Gedu sir and Dr. Madam Deshmukh Madam on sir's lecture, and then we will go on discussion for the queries in the chat box.
Yes, Shubada Deshmukh, you want to say something?
Okay, sir. Am I audible, Manisha? Because for me,
Yes,
the connection
yes.
has been very unstable, and
No, you are audible.
Yeah. Okay,
Yeah.
thank you.
Sir, I will request Kundra sir to stop sharing the screen so that everyone will be. Yeah.
Kundra sir, that was really a wonderful deliberation. And when I lost connection here, I switched on to the YouTube and I desperately was following your lecture. I didn't want to miss a single slide. And it was a description which was so easily and so logically put. And the approach, as you said, for a patient who is intubated but difficult to ventilate can be a very frightening experience. And the approach has to be standardized and in a systemic manner, moving from the most life-threatening to the least life-threatening, as you have put it. And the algorithms that you have put and you have shown are really helpful. Sir, and what I best like about all your lectures is the simple way in which you insist that the things should be done in a right way, like the T-piece adapter and should be the equipment should be held upright and all. It's so important, but often not mentioned. And so this is absolutely wonderful to impress on the young minds how it should be done. Thank you very much, sir. And that was a wonderful. Thank you.
Thank you, Shubda Madam. Gedu sir, please.
Well, Dr. Kundra sir, it was an amazing one, and more important that you shared the experiences which you had in your institute also, and some publication where even your institute was also involved. That was a good one. But if possible, can I add a few things, if you don't mind?
Yes, sir. I would like to learn from whatever experiences you have.
So the thing is, there are couple of things which was to be added or missed was that if a patient already has, for example, you have intubated successfully, but if the patient has got a tracheal tumor or a tumor at the any of the bronchus, In that condition, you will not be able to, even under carina, you won't be able to intubate, though your intubation is successful. You can't ventilate such a patient because of the obstruction. Or if there is a pressure on the trachea coming from the outside, that is from the thorax, is there any tumor, maybe in the superior mediastinum or any malignancy of the lung, which is compressing onto the trachea. In that condition also, though your intubation is fine, but the compression may be below your intubation. So in such condition also, it's difficult to ventilate. Another thing I have seen, I have got a couple of photographs also where it has been shown that the cuff, whenever we inflate the cuff, whether it is double lumen tube or even our routine endotracheal tubes, in such a condition, the cuff can herniate and obstruct even the outlet of our endotracheal tube, that is at the distal end. There are photographs of that also. Same thing is photographed with your LMA or even the tracheostomy tubes. That is also there. So these are the few which I thought I should add on.
Thank you very much, sir. I think in the third slide itself, I mentioned about the herniation of the cuff and intraluminal obstruction.
That was intraluminal, but now I'm telling you extraluminal.
Yes,
That means the cuff goes beyond your what you call distal end of the tracheal.
Absolutely.
I mean, distal end of the endotracheal tube, not trachea. I'm sorry.
Absolutely, sir. You're right. And I'll just let me come to this part. Let me show here. I think it will be so that we re-emphasize this part. So this is what I mentioned here, that with an overinflated cuff, you can either have cuff herniation or intraluminal obstruction.
Correct.
Both things are possible. And I totally agree with you that these are the issues which we need to look at. And these are things which are normally done. But thank you very much for the about the endobronchial tube. I specifically did not venture into the thoracic anesthesia part, because these are very difficult cases and they have to be planned beforehand, where you need to have the.
So that is the reason I think why what happens is we should also go
Yes,
through the file and ask the surgeon what is your provisional diagnosis.
absolutely.
Is it there is a tracheal tumor? Is it a carinal tumor or it's a bronchus tumor which is obstructing? So even if I want to ventilate, I will not be able to ventilate at all because it's beyond your endotracheal tube. Everything is fantastic. Your intubation is superb, but
Yes,
you can't ventilate because of the distal end problem.
totally agreed.
So
Thank
Sir,
you.
I would like to say something about the tracheal cuff, which was herniated. It has been mentioned that the wire enforced tubes, which have a soft tip, the distal portion which is soft, the cuff herniation was more common there, where it could be compressed. Now, with the current tubes, the distal end is not that soft. And have you seen recent cases where this the cuff herniation has completely obstructed the tube?
yes, I do have the photographs.
Yes, madam, I have seen them, and they generally occur with the latex.
Yes.
Another thing, what you are committed about the, let's say, armor tube also. We always believe that armor tube is the most unkinkable and etc. etc. But I do have a photograph where the wire of the what you call the armor tube, at one place it is missing. From there, the tube gets herniated inside. So that also picture I have got. So that is also possible.
Okay, sir.
And that reminds me one incident which occurred way back when I just finished my MD and one of my resident was giving anesthesia. Well, I'm talking those days when we had the red rubber tubes. You know, those earlier endotracheal ETT tubes were red rubber tube. Today, of course, we have got a Vortex which is colorless PVC. I mean, we can see inside. But those days, that tube, luckily it so happened what you said correctly, that whenever it is a reusable tube, I'll always suggest that you should put a suction catheter through it so as to make sure that your suction catheter is going very easily till the distal end. And that also you should do after putting that suction catheter, inflate the cuff before intubation also and see whether your tube is, suction catheter is going perfectly well or not. Because sometimes the tube, the cuff can get herniated inside. Another thing, what happened in my incidents, what I was talking in my institute, it happened. This is in Solapur, I'm talking, Manisha. So at that time, it was a red rubber tube. And once, luckily, I put a suction catheter inside. And can you believe I didn't put on the suction? It was not getting sucked. I just put the catheter without connecting it to the what you call suction machine. When I put it inside, can you believe small dead cockroach came in front? So thank God we didn't intubate, because otherwise the dead cockroach would have been in the patient's lungs. So that things can be possible. So it's ideal what you said correctly, that before whenever you are using a reusable tube, particularly red rubber tube, you should always suction catheter so as to ensure that it's been patent throughout with cuff inflation or without cuff inflation, both.
When the photograph which was shown by Sir Ascaris lubricoides at the top, at the tip of LMA.
Yes,
that
was amazing. That was an amazing one.
That was really scary. And actually, yes, all these instances where the cuff, these were common with the red rubber tubes, and they were exceedingly, I mean, they were reused to the extent that they would have become sticky. And I just can't imagine how we used to reuse all those tubes for so many months, years. But nowadays, I think that problem has gone, and all of us use the tubes which are Portex or even the silicone cuff tubes, micro cuff tubes. And
let's go on to the question and various questions that
I think we should share the questions now.
Yes.
Yeah.
So one comment was there actually. He has asked question that an intubated patient, he intubated a patient and atracurium was given and there was severe bronchospasm. The chest was stony hard. He gave adrenaline, the half cc. And so was this anaphylaxis to atracurium? That is what the doctor wants to ask.
Correct.
Kundra, sir.
Yes, this is one of the issues because atracurium is known to cause histamine release. At times, the histamine release may be inappropriate to the dose, and it can lead to such kind of catastrophes. So, whenever you have such an incident, I already emphasize that adrenaline is the lifesaver, and that is what will help you out in case you have such a situation.
I will add on few more things here. That atracurium is known for it, and second thing is whenever we use a morphine, atracurium, plasma volume expanders, these are the things which are known to cause allergy in certain patients. So in all these patient can have a bronchospasm also. Bronchospasm can be mild, severe, but of course what Kundra sir has said is correct. The remedy should be adrenaline will be your first choice, or nebulization with any bronchodilator will help us definitely.
So even this atracurium, the second dose is usually known to cause severe anaphylaxis. Like if we give first dose, the patient may not get the signs of anaphylaxis or bronchospasm, but when we give top up, then the second dose is known to cause more kind of anaphylaxis than the first dose. That's what is mentioned in the literature or in the books.
It can occur with either of the doses. You can have it with the intubating dose also because a mega dose. Correct. So it's not always the rule. But whenever you give such drugs who have a potential of having histamine release, you need to be careful and watch out for such. Correct. And then treat them accordingly.
Yes.
Another thing, there are some people who are very hypersensitive to certain antibiotics, and surgeon always asks once we induce anesthesia and they start the surgery, before that they tell you to give some antibiotic. So there is a possibility you may be allergic to that antibiotic and you may go into the bronchospasm, anaphylactic reactions. So that not anaphylactic, anaphylactoid.
Okay, ma'am, can I share an experience today? We had a We had a case, colostomy closure, a young man of 45 years. Now, he had 3 surgeries before, and for which general anesthesia was given. Last 2 years back, he was anesthetized, ceftriaxone, thiopentone, and then vecuronium was administered, and he had severe reaction. Reaction means hypotension, tachycardia, severe bronchospasm. They had to start with epinephrine infusion. Then with the epinephrine infusions, they were able to maintain the hemodynamics. And then we transferred him to ICU, and where he was kept for a day and he recovered. So today he was posted again for colostomy closure. So this person was again retested for hypersensitivity reaction. he was sensitive to, he showed hypersensitivity to ceftriaxone. He showed hypersensitivity to vicuronium, very surprisingly. But for rocuronium and thio, he didn't show any hypersensitivity. So those are the drugs we could use. Now, how do you test for this hypersensitivity? Because you will be using these agents day out and day in. What it is called a skin prick test, or a skin prick test, where you put in a drop of the agent on the volar aspect of the forearm and just give us a small prick onto the skin. And then you have a control with normal saline. If the wheal is 3 millimeters or more, then the patient is supposed to be a hypersensitive. So all of you can do this kind of a test. I mean, it's not an intradermal test. It's just a skin prick method of testing for the agents which can cause hypersensitivity. So this is the way we could do. We could find that he's hypersensitive to such drugs and could use alternative drugs which didn't show a wheal of 3 millimeters or more. So just to share an experience how you could check and how you could standardize your anesthetic technique if the patient is having such allergic reactions.
Kundra sir, when you tested this by the skin prick method, the patient showed only hypersensitivity as far as the skin reaction was concerned, but he did not have any systemic manifestations of that. I mean, the dose would be minimal, I agree with that, but once the anaphylactoid reaction starts.
So ma'am, it is, this is the best way of doing it. At least you rule out those drugs which you are not going to use.
True.
It only was a skin prick method where you could see that there's a wheal which is happening, and at least you could make sure that you do not use those drugs at all, and you can use other drugs where the skin wheal was not produced.
How much amount the drug you inject?
Just put a drop of drug onto the volar aspect and then just give a small prick with a 26 gauge needle.
Okay.
So the drug is not injected. I think the drug is just kept on the skin as a drop.
Absolutely.
And then you prick, yeah. So
that is why the absorption was less. And
that's how it is. Just to tell you that we all can do it, because for intradermal testing you need to have exact dilutions of the drugs, and if drugs have different dilutions, it's difficult to do and standardize, but at least these ones can be done frequently, and we can also have a look at it.
Next question, I think there is a comment from ma'am, Anila Malde madam. There is a major leak in breathing circuit. If there is a major leak in breathing circuit, it will cause rise in PaCO2, but decrease in EtCO2. So that is a comment.
There may be a rise or there may be a fall. It can occur both ways. It depends how much you are able to ventilate. So if you increase your fresh gas flow, you will find that the EtCO2 after increasing the fresh gas flow has risen up. But there is a major leak and you're not able to put in anything, then you will hardly able to get the expired tidal volume, and then the EtCO2 trace will be very low. So it all depends how much of your bag is getting refilled.
Okay. Anita madam, next question please.
Yes. One doctor has asked why we cannot use same peripheral line after the magnesium sulfate injection.
You can use it, ma'am. I said no, you can. It's not that you cannot use, but it has a tendency to cause thrombophlebitis. That's the only issue. So
because it's irritant.
Yeah, it's irritant. It can cause that, and at times, in certain susceptible individuals, you may have to have another line.
But if you are using a very small bore needle, then it is going to be troublesome more. But if you are using it in a large bore needle, it is safer. Nothing long.
Okay. There is one more question. How nitrous oxide can increase curve pressure?
Because it diffuses into closed spaces, closed airway spaces, it can diffuse inside and cause increase in pressures.
There are many publications. What sir is saying is correct.
Yes. Again, Malde madam has commented that magnesium sulfate is given very commonly for bronchospasm in children and is given through peripheral line.
You can give it. I never said you can't give it, but always be sure, be a little bit observant that it can cause thrombophlebitis.
Yeah.
Sure, sir.
There is another question. At intubation, there was a vocal cord noodle that went with the tube and caused obstruction. Total occlusion occurred, which we realized later. So this is, I think, a comment by Dr. Pankaj Gupta.
So we have seen those things happening quite often. Unfortunately, those are such acute incidents you can't keep photographs of them. So we could see that one of the patients who had a small granuloma and it was causing a lot of obstruction, and we were not able to ventilate the patient at all. So by the time we removed the tube, passed in a smaller size tube, it was all gone. So it just disappears at times, and then you can dislodge those kind of granulomas or polyps which are there, and they at times can also obstruct their lumen. So all we need to remember is that there are possibilities of obstruction to the tracheal lumen. There can be numerous possibilities. Some of them are common, some of them are rare, but the only way is how to rule out or find out whether there is a tubal obstruction. That is the mainstay of what the message should go across. It's important that we first identify that there is some obstruction. Secondly, we try to see where the obstruction is. Is it at the tube? Are there certain patient factors? They can be around the connectors. Sometimes the connector itself can collapse. You use normally plastic size connectors, and someone has forced it through, the whole lumen of the connector is gone. So like Dr. Gedu said, you use a reinforced tube, the wires are broken, and as soon as the tube is twisted, the whole lumen of the tube is gone, is obstructed. So there can be numerous examples of tubal obstruction, but the mainstay should be how to find out there is an obstruction and how to treat or manage it. That is what we need to focus on.
Sir, I would like to just narrate one more example. This comes from the earlier days when we did not have many anesthesia ventilators and we were still ventilating by hand. And I remember that we intubated a child and we gave proper position. And after that, though we could ventilate, the return to the bag was not satisfactory. And many a times when we hand ventilate, this is the way we can find out if there is a partial obstruction. That when we would give IPPV, the patient can be ventilated, but the return to the bag is not sufficient. So it is important to recognize that this part also, and then we repositioned the patient's head, and then we could easily ventilate and get the return back again. That is also so. The feel of the bag and the feel of the bag not only during compression but also during the return is also equally important when you want to detect any obstruction.
That also depends on the APL valve, how much you are closing the valve. Because
right, Anita, but with the APL wall being the closure being constant, when you don't get a sufficient return, that also should ring bells in the mind when we encounter this problem.
Dr. Preeti has asked that when you are doing the test for the skin prick, the reaction, so do you need to dilute the drug when you are doing this test? Through the drop you are pricking the skin?
No,
you
ma'am.
need to dilute?
You don't have to dilute.
And how long do you wait for skin reaction after the skin prick?
You at least wait for regularly for 1 to 2 hours to see if there's a wheal developing.
1 to 2 hours for the wheal. Okay, so it's a long time.
You will have to put a circle around that and then see whether the wheal. It has to be done 1 day before.
Yes.
Okay. One doctor is sharing one of the case report. He has faced severe bronchospasm in a patient who received neostigmine for neuromuscular block reversal. The patient was spontaneously breathing and he suddenly landed up in bronchospasm. It was luck that he was not extubated, yet managed with injection adrenaline 0.5 milligrams subcute.
No, it was the same case actually.
So the important message what sir has given, Kundra sir has given, is that one should be bold enough to give IV adrenaline in such situations, which will definitely reverse everything and in fact will be helpful in maintaining hemodynamic stability also.
So it is a lifesaver, and the beauty of adrenaline is that it is present in all the OTs. Like it will be there in a general practitioner's theater also.
Even if you're afraid of giving IV, ma'am, if you give subcutaneously also, it will work.
Yes.
Yeah. Sir, but if there is a doubt for anaphylaxis and if there is a severe bronchospasm, it is always, and there will be, at the same time, there will be hemodynamic instability also. So it is always better to give adrenaline IV first, and then you can put an infusion also.
Dr. Manisha, there is there's a catch there. At times, the patient may have tachycardia. The heart rate may be 130, 140.
Okay.
And at that time, you may be a little reluctant to give IV adrenaline because it can induce VTAC or something of that sort. Arrhythmias can happen. So if your heart rate is high, but the BP is kind of stable, and still the patient has severe spasm, use it subcutaneously. But if your heart rate is a little bit on a lower side, and then you can actually dilute the epinephrine and slowly give it off to achieve that effect. That is how I will put it. But most of the time, subcutaneous epinephrine works. You can even nebulize epinephrine and give it, but make sure you have a separate oxygen source and a nebulizer connected to nebulize it up.
Yes, it is actually commercially available nebulizer with a T-piece. It's available.
Yeah, but you can put it to the tube. No, if the patient is intubated, you can put it to the.
You can connect it to the tube, and then it gets connected to the tube.
Yeah.
Where I said, sir has emphasized it has to be used in a erect position properly.
Yes,
Yeah.
very important. For any nebulizer to work, actually, it has to be vertical.
But
Otherwise,
for epinephrine, I think you can even instill 0.5 milligrams into the tube and ventilate.
The tube, yeah.
It doesn't.
I think, sir, we can dilute epinephrine in a 10 cc syringe, and we can give it slowly, titrating with the hemodynamics and with the response, because it works beautifully if it is given diluted and given IV.
Yes, ma'am. I totally agree.
Anita, madam, next questions, please.
yes. So this 10 to 50 micrograms adrenaline IV in an adult. In this, we are talking about the adult, no, sir?
Yes, ma'am.
Yes, yeah. The same doctor is asking that is it mandatory or compulsory to use flexometallic tube for general anesthetic in prone position, like spine surgery, PCNL, from medico-legal point of view? Actually, it is not related to our topic.
My answer would be that nothing is compulsory, but if you have a flexometallic tube, a PVC flexometallic tube or a reinforced tube, you generally avoid kinking of the tubes, which can happen. And what we have noticed is that at times, if you use PVC tubes and the patient is in prone position, the kinking happens within the oral cavity.
Yes,
intraoral. Yes. Intraorally it happens. That is where the problems can occur. And then it is very difficult to correct that, because then what you'll have to do is you'll have to pull the tube out for that extra length of the tube which is inside the oral cavity, and then make sure that it doesn't kink. So it's better to have a reinforced tube and be on a safer side and work without having those kind of tensions.
Yes, after proning, it is known that the tube shifts to one side because after proning, the head gets flexed and then the tube shifts inside, and it can get kinked intraorally.
As the temperature as it adapts to the body temperature, it gets softened and then it tends to kink there.
And if the surgeon wants to operate on the occipital or the upper cervical area, they flex the neck, and that flexion can cause obstruction. So it is always better to go for reinforced tube rather than for the Potex tube.
I agree.
Yeah, Dr. Gauri Arora is asking, can the cuff deflation failure to be done in cuff deflation failure? Does she mean that you are trying to deflate and the cuff is not getting deflated?
I have seen such conditions, and it's a very good question. I thought I should have also mentioned this, but it was not difficult intubation, difficult ventilation. But there are two ways of doing it. As I think Dr. Pankaj has mentioned that you can use a needle to deflate the cuff. For that, you will have to pull the tube towards the cords, and then do a laryngoscopy and see that you puncture the cuff just beneath the cords. At times you may not get that margin of safety. The best way would be that you go from just like you do a cricothyroid puncture, right? So you can go from here, just put the needle inside and the cuff will get punctured immediately. So you can go percutaneously to do that. If you are really wanting to be very precise, just use an airway ultrasound locate the cuff and I guide the needle percutaneously, puncture the cuff and take the tube out.
Yes, with ultrasound, everything is becoming in sir's slides also. For all conditions, sir is telling all different signs, seashore sign, B lines, A lines. So use of ultrasound is a must.
Now, in that condition, I must say, comment also one thing, that whenever you are getting that cuff is not getting deflated. Apart from what sir has said is correct, but the thing is one more thing that we have also done a couple of times where there is always a loss of connection between your pilot balloon and the cuff. So best thing is, since the tube is anyway going to be destroyed, cuff is anyway going to be destroyed. So what I do is I cut the connecting tube that is there. So once you cut it there, it automatically gets deflated. So that is also one of the possibilities. You can try that. If that fails, then we can go for a needle technique.
Yes, because cutting the tube is more simpler.
Simpler way, and it's not damaging to the patient or anything.
Yes. One query is, while giving adrenaline, we must have defibrillator as a standby in OT.
No.
Okay.
It's precisely what I was telling Dr. Manisha, that at times you can induce some sort of arrhythmia, so you have to be a little careful when the heart rate is on a higher side. But normally, I agree, IV is safer. You can use, but if you are reluctant, you can use either of the routes. But please use epinephrine. That's the way I will put it.
Yes.
Yeah. There is a comment. Sometimes even there is a failure to canalize the connector end by manufacturer. So my colleague couldn't ventilate. So visual confirmation of both the sides of the tube is necessary. I think I have read about this case report on one of the Facebook group of anesthesiologists, that the another end, the connector end, was totally occluded and it was a manufacturer defect. Very good comment by one of the anesthesiologists. Any comments, sir? We used to we used to check it by putting a stillet so that can get confirmed that there is no manufacturer defect. Sir,
Manisha, I have got a photograph also with me. I got a slide with me, whereby forget the connector problem, manufacturing defect. There is a manufacturing defect of your mask also, where the connector is to be attached. Even there, there is a sort of a screen over there which is not been cut, and thereafter, even if I attach the connector, I will not be able to ventilate. That I got a photograph also.
So the echo message can be, yes, sir.
I think I showed that slide in Sholapur. Okay. I remember that.
The take home message can be, you have to, even if it is a new tube, you need to check it.
100%. You are right. Absolutely. Yeah. Absolutely right. Yeah. Pankaj, I want to add one more thing in the obstruction part, what we said, difficult to ventilate. You know, many times whenever we are putting a nasal intubation, we do. I have got a photographs also where it has been shown that when you put a nasal endotracheal tube, there may be some polyp or adenoid which is getting stuck into the endotracheal tube, which makes, or even blood clot, because the bleeding has occurred and it has not been, you are taking a longer time to intubate. So I got these 3 photographs where adenoids are there, blood clot is there, and all those things are there also, which ultimately, though your tube is inside the trachea, but still you are unable to ventilate.
So even an inferior turbinate getting lodged in the nasal in the tube during nasal intubation has been reported.
Yes.
I agree, sir.
When there is one machine checking when the people do, for example, if you have done one case earlier, and now you tell the OT boy or technician to clean the machine, there is a what case report is there where at the common outlet of your connector from the circle absorber, the connector has got a cotton plug inside, which was, they failed to remove it. And we people did notice, so we connected to the endotracheal tube and we tried to ventilate. Because the plug is there, if the patient was unable to ventilate. So it was not a single defect with the patient or our technique, but it was a problem associated with the cleaning or something like machine-related problems.
But I remember once thread of the gauze was there, which was stuck in the expiratory wall because that valve was opened and cleaned before induction. And though there was no bronchospasm, but there was rising EtCO2, and when we took the patient on hand and ventilated him, there was no problem. But once we used to connect it to the ventilator, we could see that there is a rising EtCO2. So that gave us an indication that there is some problem in the machine and not with the patient. So I remember
What-
that incident after you told about
This what you have said is also correct. One more thing we must say that when we were using these non-rebreathing valves, or even if I'm using a what you call one-way valve, in such a condition, when you use it for a longer time, the expiratory gas contains moisture and all those things. So that basically makes your expiratory valve get stuck. So there your progressively your EtCO2 will start rising. So that's also one of the factors. I'm not saying that's a difficult ventilation, but that's your EtCO2 is still rising. There's no bronchospasm, there's nothing, but still the EtCO2 starts rising.
Malde madam has mentioned that she has preserved half dozen of connectors with membrane. She has already reported.
Yes,
it in
yes,
detail.
absolutely right. She's right, absolutely right.
Half dozen looks like it is quite common, more common than we think.
It is common only with around when Malde madam is around.
Sir, as far as the connectors go, we were told by our teachers when we were using those metal connectors, sometimes the residents would use them to break the ampule tips. And there were cases. There was a case where after intubation, it was very difficult to ventilate, and ultimately they found that the the ampule tip was lodged in the connector.
Correct.
And this was narrated to us. I've never faced it myself, but like this was told to us.
You are absolutely right.
Any more questions, Anita?
No, actually, anybody wants to share their experiences?
Hi, sir, please unmute.
Yeah. Pankaj sir.
Yes, sir.
Very excellent slide of that Ascaris.
Yes, sir.
I have an experience. Both were tonsillectomy patients, and I could notice once a bundle of Ascaris while intubating, and with the Magil forceps I was taking out the Ascaris. And once only one this thing, both were tonsillectomy patients.
Yes, sir.
And since then, I told my ENT surgeon, henceforth, unless until deworming is there, I am not going to induce the patient. Subsequently, he also realized.
Yes.
And after a couple of years, this is around 2000, after a couple of years, I stopped doing the tonsillectomy itself. That's one more thing, sir, I want to ask.
Yes, sir.
As
Hello.
Sir,
sometimes they try to put after the minor procedure diclofenac suppositories. And after putting the diclofenac suppositories, has anybody noticed the bronchospasm? And are there any reports of diclofenac inducing while putting this suppositories, particularly I'm talking? Diclofenac is known to cause the anaphylactic reaction, but suppositories, has anybody has got that noticed bronchospasm? Your view about this?
Sir, I would suggest use paracetamol suppositories. They are equally effective rather than using NSAIDs. I think that's the best way. Paracetamol is the safest drug which you can use. And somehow I always feel comfortable when we use things which are much safer, which have a much safer therapeutic index and safety index, rather than using NSAIDs which can create problem in children.
This comment you made. Okay, that comment was for adult patients. Sorry, sir?
Yeah, exactly.
Yeah. Dr. Shashi Patil has raised his hand. Dr. Patil, sir, can you unmute yourself?
Yes, I have unmuted. Can I ask one question to sir?
Yeah, please.
Yeah, I was doing a very obese patient, about 100 kgs, more than 100 kgs. She was short-statured and she was being operated for lumbar spine. After intubation, when we kept the patient in prone position, till the when she was upright, the pressure and everything on the machine was normal. But when we kept her in prone position, after 5 minutes, there was high pressure indication and there was a alarm going on, and surgery went for around 3 to 4 hours, and all this time, their machine was showing high pressure. I checked everything, the oxygen pressure, then whether the tube, I was using flexometallic tube. Even though I checked whether it is kinked, and nothing was there. So whether the prone position has given rise to the high pressure, and what should be done if such thing happens?
No, actually prone position is actually considered better than supine for ventilation. So, I mean, just the prone position will not give rise to high pressure, I think. What do you think, Kundra sir?
See, in obese patients, when you give prone position, we have to make sure that the patient is positioned properly. The diaphragmatic excursions should be absolutely free. The abdomen should be absolutely free. If the abdomen is not free and and the diaphragmatic excursions get limited, then you will always get a high pressure, and it will be very difficult to manage. So I personally feel that when you give heavyweight patients, especially 100 kgs and others prone, you would find such a problem, because positioning them is very difficult in prone position. To elevate them so that the abdomen is completely free is a difficult task, and that is where the problems can occur.
Yes, you need specialized frames made for them. Otherwise, you can just use any pillows and
bolsters were used. Sorry to interrupt. Bolsters were used, but what happened is throughout the surgery, it was showing high pressure. So my question is whether the patient was ventilated very well. Was there any problem in her ventilation, though the machine was showing high pressure? And what should be done if such thing happens again?
Madam, you have to rule out even the thoracic pressure also. Since you said you are using bolsters, so was there any compression of the chest also? Like what sir said about the abdomen should be totally free, and in a obese patient it is difficult. So at the same time, you have to see even the thoracic compression is not the bolster that is resting on the thorax, whether it is causing compression. That also you have to see, and whether also you have to check your neck position also. Whether there is some kinking of the neck or whatever, that also you have to rule out. What was the surgery, madam? Because if it is...
It was lumbar spine.
Yeah, so the head was resting on the horseshoe, or...
No, madam. It was on a pillow. On the pillow, we had kept a ring. On that, we had kept a... see, our setup is a small setup. It is a private hospital. Nursing home rather, and the patient was kept on a pillow. On that the ring was kept, and some cotton was kept, and on that her face was kept. That was that is done always. But what happened, I think so, it is thoracic compression which has given rise to this high pressure. Even I asked the surgeon that is there some problem with the thoracic this thing, that diaphragm is not getting properly expansion and all that. So that is giving rise to the high pressure on the machine.
Madam, may I ask how much was the pressure?
Yeah.
I mean, is there a possibility that the pressure settings were not optimum for that patient?
Madam, my machine is some 5 or 6 years old. There is no pressure ventilation and this thing. It is just normal this thing.
You can see the peak airway pressures, madam. Peak airway pressures.
It was no, I don't remember.
Alarm देत होता म्हणून म्हणते मी की alarm improper settings असले तरी देईल ना, म्हणून म्हणते मी की what was would you be able to tell us how much was the pressure airway pressure at that time?
No, sorry, I didn't see that on that time because I was under so much
ETCO2 was okay. The ETCO2 was okay.
ETCO2 was okay, I think so. But the alarm was constantly going on. So just I want to know whether the patient was ventilated properly, no?
Madam, the patient may have been ventilated properly, but it would have required high pressures to ventilate the patient. That's all about it. Because if you have a doubt at that time, you can look at your ETCO2. If the ETCO2 is normal, and if you look at the portion which should be plateau, if it is slanting upwards, you will know that there is some sort of an obstruction which is happening. And normally, if you look at the ETCO2, it will tell you whether the ventilation is appropriate or not. And if the saturation and ventilation and ETCO2 are fine, then you are able to achieve ventilation, but you are requiring higher pressures to achieve that. That is all about it.
About it. Okay. Thank you.
Listen, in your patient, I would have preferred that since you said you used a pillow and thereafter you use a bolster or whatever it is, I think. So I would have preferred that remove the pillow, keep a bolster, and instead of that, I would have just kept a small bolster just below the both shoulders, so that your chest is being raised up and your neck is being little down. So that would have made a big difference. It would have not allowed any small amount of kinking as well as chest compression, which is occurring because of the heavy weight.
Yes, sir. Yeah. Anyone wants to, any question? There is a question.
Thank you, sir.
Yeah, there is a question whether there is a role of nebulized magnesium for acute refractory bronchospasm. Nebulized magnesium.
It's difficult to nebulize magnesium because I'm not very sure. I've never used it. I would rather use IV magnesium rather than nebulized magnesium.
Yes, and nebulized adrenaline works very well actually.
Yes, it works.
I just wanted to share one experience where one child of cleft palate was very difficult to ventilate. And when I put in the scope, there were huge tonsils, almost 2 tumors in the throat, kissing tonsils. So such huge tonsils were there. So that was leading to the obstruction.
Anyone who wants to make any comment from the audience or share their experience, they're most welcome. Please unmute, and then otherwise we will end the webinar.
Yes, no more questions.
Can I ask a question, madam?
Priti, yes, please.
Yeah, I have actually typed this earlier. I had a case recently, an onco case. It was a maxillectomy, and not a maxillectomy, sorry, this was a modified neck dissection, just a plain modified neck dissection. The mandibulectomy had already been done before. So this was mainly MND along with reconstruction. Now here my surgeon wanted me to extubate on table because it was a short procedure, happened very fast, and he was quite confident. Now the thing is, after deflating the cuff, I could not pull out the tube. And I tried turning it this way, that way, re-inflating, deflating, tried a few stunts, nothing happened. But my oncosurgeon just walked in and he yanked the tube out. I mean, my heart was in my mouth when he did that. But my question here is, if something like this happens, how do we deal with it? Any tips and tricks, sir?
Actually, you should use this happens with the old tubes or the vortex tubes, which have tendency to bunch up the cuff. So if you use a newer silicone tubes, they cuff when
this
you
was a new tube. This was a new tube, and this has absolutely happened to me for the first time, that I could not, take it out, and I tried my best, but nothing happened.
What did the surgeon do? I didn't get.
He just pulled it out. He just pulled it out. I thought the vocal cords would come with it. It was barbaric. It was frightening for me. I couldn't sleep that night actually.
So he pulled out forcefully. So he pulled out forcefully.
Was inflated or deflated?
Oh, then in such a condition, I tell you one thing. In such a condition, I know though surgeon has pulled out, it has been successfully pulled out. I know it was scary. So what I would have preferred, because I worked in Tata Memorial for 25 years. So in such a condition, whenever there is a difficult one cases to extubate also, or this is going to be collapsing afterwards once we remove the tube. So I always put a bougie first inside, and thereafter I don't mind pulling it out whatever way, because at least my bougie is inside. So God forbid anything again I need to re-intubate, I can just put it over the bougie. So that can be.
That's a great idea. So this guy pulled it out before I could react. I just said, "Sir, tube nikal raha nahi hai," and I was just trying and manipulating it, and he just came in from the foot and he just yanked it out. He was standing at the waist of the patient and he just pulled it out. I actually did an endoscopy, this laryngoscopy, to see whether the cords are inside or they have come out.
Yeah. Any more comments, please? Anyone wants to ask? Yes, Dr. Sandeep.
Yeah, I would like to give. It's a recent case. We had a rotor accident, facial injuries with head injury, and patient was already intubated, and he was brought to this for surgery, for plastic surgery of facial injuries and all. Thus, actually, the surgeon said that we are going to keep him on ventilator because the patient may require prolonged ventilation for his CNS condition. So on table, we connected to the machine, we started anesthesia process and all. And on table, he started with his tracheostomy and he put in the tube. And after putting the tube, it was becoming difficult for us to ventilate and patient started desaturating. So first thing what we thought, okay, probably blood clot is there. We started suctioning from it. Then it couldn't relieve. Then the first thing what I did was just check the cuff pressure because the surgeon had put the tube and he had inflated the thing. When I checked the cuff pressure, it was around 150. Then just I deflated and we could ventilate. So this is the thing, the cases which were described earlier, because of the cuff getting in. This was with the tracheostomy, new tracheostomy tube. So we have to check the cuff pressure, what they have inflating. The surgeons do that. So we have to check that as well.
You're right, sir. Absolutely right.
Absolutely. Yeah. Very nice experience and thanks for sharing.
Okay, thank you.
What must have happened to the mucosa?
But it was transient. Okay.
I see, it was transient. He did it and we couldn't ventilate. Okay. That was the thing.
Okay. There is one question. Role of theophylline or aminophylline for treating bronchospasm? Kundra sir.
No, not really. Because if you look at aminophylline and theophylline, they tend to wake up the patient. They are antagonistic to sedation. They do not, and aminophylline has got a very low therapeutic index. So if you have given a beta-2 agonist and you try to give aminophylline, the patient can have issues. So I would not recommend using them. You use beta-2 agonists, you can use others, but not theophylline and aminophylline.
Okay, sir. If there are no more comments or no more questions, I think there is a comment. No.
Thank you very much, Dr. Manisha, for keeping me here. It was a pleasure interacting with all of you.
Sir, we are really thankful to you for the time spent by you.
I'm also very impressed that it was very interactive. So many questions came and it was very interactive.
Yeah.
Very interesting one.
And sir,
wonderful session.
So many people are still logged in since last 2 hours. So it was really wonderful, sir, and we are really thankful to you for giving so much
Thank you, Pankaj sir.
For our state.
It was a good one.
Yeah. We'll just complete the formality. Samir sir.
गेडू सर आपकी वो कल का टॉक का शेयर कर दीजिए.
क्या?
लिंक आपका कल टॉक है ना, कुंद्रा सर ने भी बोला था आपको कि वो लिंक शेयर कर दें.
हाँ, मैं करता हूँ शेयर.
हाँ सर, प्लीज कीजिए.
मैं कभी अभी बता दूं क्या?
नहीं लिंक शेयर कर दीजिए ना.
नहीं, ये कल का क्या है, that is for the national board webinar है, so they are not going through the Zoom. They are going through the WebEx type of very different one. I don't know whether really share the things or not.
नहीं, वो आपके फोटोग्राफ्स तो होंगे ना सर उसमें. आप जो फोटोग्राफ्स की बात कर रहे हैं वो तो काफी होंगे उसमें, इसलिए आई थॉट.
मेरे पास तो फोटोग्राफ तो अभी भी है मेरे पास.
ना सर, मैं आपके प्रेजेंटेशन में रहेंगे तो हमको देखने को मिल जाएंगे, ऐसा मेरा कहना था.
Sir, you can share your slides. You can share your slides, sir.
Now?
Not now. Once you present, you can share your slides.
Now it is bit, I think, okay. Because the thing is, in that webinar, I don't know whether national board is permitting from any common people also over there. Because this is only for the national board registered people. Because it's a national board webinar.
Okay, sir. So we'll discuss this topic again.
Yeah, that's fair enough. That's okay.
Manisha ma'am, stop करो का recording?
No, just a minute. Dr. Samir is going to do the formalities of vote of thanks.
Because Kundra can disappear.
No, Kundra sir is still logged in.
Yeah.
Yeah.
उनका चेहरा नहीं दिख रहा है.
गेदू सर है अभी, कुंद्रा सर है.
आहे.
नाही सर, कहीं नहीं गया. मैंने
मला वाटलं तिच्या याला समीर मला ओळखत पण नाही नालायक साला.
I was thinking लोग होंगे मेरी शक्ल.
Let me do the formality of Thanksgiving. I am very much thankful to Dr. Pankaj Kundra for his excellent deliberation on this difficult topic, and for being the chairpersons, Dr. Gedu sir, Dr. Shubda madam, all the office bearers of Maharashtra State ISA, and all the participants who watched this webinar, watched this masterclass on this Zoom platform as well as on the YouTube. We are getting excellent response in these academic sessions. So I'm very much thankful to the Jenica Technology for their technical support, and hope to have excellent interactions in the future also with our masterclass series. Thank you very much.
Thank you so much. Thank you so much.
Yeah, thank you
Thank
all.
you, Chandraji.
Thank you.
Yeah. Let's meet on 20th again, 20th of May, with the interactive debates on airway and ventilation. So we have 2 interactive debates on 20th of May. Thank you so much.
Okay.
Thank you, ma'am. Thank you.
Thank you, sir.
Thank you, sir. Thank
Varsha,
you.
you can
Thank you, everybody.
stop
Thank
recording.
you, Gedu sir. Varsha,
Thank you,
stop
everybody,
recording.
and good night.
Yes. Good night, sir. Good night. Good night, Gedu sir.